Hi, I am Tonya Moschell. I'm a registered nurse and a full-time nursing instructor at Oglala, Lakota College, here on the Pine Ridge Reservation. I'm studying Indigenous Public Health through the University of North Dakota through a program sponsored by AHEC. And pleased to share a recent project with you addressing diabetes prevention and management through the health belief model. For this project, I applied the health belief model to the prevalence of diabetes among the indigenous populations, specifically American Indian and Alaska Native populations, and I looked at conditions right here on the Pine Ridge Reservation. I took into consideration contributing factors and related social determinants of health that impact the high rates of diabetes among American Indian populations, and then looked at how the health belief model provides a construct for approaching diabetes prevention and management. So what is the health belief model? It's not a new idea. It was initially developed back in the 1950s by social psychologists with the U.S. Public Health Service that wanted to know why people weren't paying attention to the education they were providing them. It kind of holds true still today. So the model has evolved over the years as a tool to try to predict how people are going to respond to the information that we provide to them. The constructs are pretty simple. The focus is on the individual. First, perceived susceptibility. What is my risk of acquiring an illness? Is it possible for me to actually get this disease? Do I need to worry? How bad will it be if I get this illness? What is the severity? If I get the disease, what's the worst that can happen? I don't think this is clicking anymore for me. Oh, here we go. Okay. Could I die? Perceived benefits of changing some of my behaviors. What do I have to gain by learning more about this or preventing the illness? Maybe I could be well. I could have a good life. Perceived barriers, potential sacrifices, challenges, costs. Maybe I don't have a car. Maybe I don't have enough money. Maybe I can't get groceries. Cues to action. These are the triggers. These are those light bulb moments that become motivators. For example, a relative losing a limb or even their life. Cues to action are often neglected in the research, and they're more influential when perceived susceptibility and perceived severity are actually higher. So think about the example of a reminder card for an eye exam. You get the card, but unless you are worried about losing your vision or changes in your vision, you're probably not going to pay too much attention to it, and you're probably not going to run right out to make that appointment. Self-efficacy. There we go. Self-efficacy, that is the person's perception that they are capable and that their efforts will pay off and will lead to the outcomes that they desire. It's the idea that I can be successful with my efforts. I'm going to breeze through the statistics. We're painfully aware of the prevalence of diabetes in Oglala, Dakota County, presently estimated at approximately 20 to 22% of the population. Some reports suggest that diabetes can be up to 8 times higher than the general U.S. population here. And it's been stated that the youth on Pine Ridge are at about 12% of the youth are at risk for diabetes. The American Indian population will tell you it wasn't always like this. Prior to the mid-1900s, and the changes to their way of living imposed by the American government, we did not have diabetes. So you can blame televisions, sedentary lifestyles. A lot of it is the change in diet from buffalo and native plants to processed foods. Ultimately, high incidence of diabetes results in higher numbers of disease complications such as amputations, end-stage renal disease leading to dialysis, and cardiovascular disease. I'm not keeping up with myself. So I heard it said earlier this morning, and it resonated with me, that our best data and our change motivation comes from within. And that's where the health belief model comes into play, because our beliefs strongly influence our health behaviors. Some of the research states that many American Indian people on the reservations live in denial about diabetes. Others just accept it and are complacent and say, this is the way it is. And then you have those that truly want to do something about prevention or managing their illness. And then they hit all these barriers: transportation, limitations on access to medicine, and healthcare. Social determinants, I'm going to just breeze through those two. Pine Ridge, like many reservations, is very rural. Public transportation isn't like having Ubers and Lyfts everywhere you go otherwise. Healthcare is limited to 3 IHS facilities and a Horizon Health facility. They're covering 3,500 square miles of reservation. Many of the people living on Pine Ridge are living in poverty. Small rural communities are food deserts with perhaps only a convenience store or processed foods available. Not all roads are good places to walk. There might not be sidewalks. Winters are long, brutally cold and snowy, so it's better to stay indoors and hibernate. And there are a lot of assumptions made about health literacy and the understanding of Western medicine. There are some efforts to educate the population. IHS, CDC, they have their programs available, but review of some of the data reveals that the number of diabetes-related amputations and other complications is not declining, so they may not be as effective as we want them to be. So this is how I applied the health belief model to an American Indian person living in South Dakota. You have upstream factors, diet, limited or misunderstood health literacy, maybe some complacency, and then all those limiting factors related to transportation, finances, and other social determinants of health. So the perceived susceptibility is typically quite high. Perceived severity, also very high. They can see the complications, the amputations, the dialysis, the loss of life. And so you put that together and you get that perceived threat. Because my whole family has diabetes, I'm at pretty high risk. On the bottom side of this, you look at the perceived barriers and the perceived benefits. The benefits, I can live better, I can feel well. Barriers, I'm not ready to change. I like Pepsi. I don't like to drink water. I don't like to walk. I don't want to have to exercise. And all these things that they give me at IHS, I just don't understand. But then you get a cue to action. One of the relatives loses their life or loses their limb, and you say, no, I don't want to do that. I don't want my life to go that way. So I am going to do something different. This now becomes a motivator. And so now I'm going to take a look at it and say, okay, Pepsi. I don't like Diet Pepsi. I'm going to have to drink water. So I'm going to start drinking water. And I'm going to start walking. And maybe if I bring some friends with me and we go to the community center, then we can walk as a group and I can start walking off a little bit of this weight and I can start feeling a lot better about it. Self-efficacy is impacted also by generational oppression, but resilience will prevail. In conclusion, health and wellness are outcomes that all humans, regardless of ethnicity, hope to achieve and maintain. By involving individuals and their respective communities in a plan of diabetes protection, ideas can be generated that take the outcomes beyond this clinical data. Reach out to people with diabetes and those living with the relatives who are struggling with the diabetes. Just like the video we just watched a little bit ago. We went to the people, we heard their stories. Get creative. Opening up community centers for walking groups is just a simple idea that I had. It popped into my model, but other things, teaching children in the community about food sovereignty and how to grow and prepare traditional foods. This is already happening. Thunder Valley Community Gardens out here, we are making progress in that arena. Make the interventions realistic and sustainable. Tailor the programs and the education to the communities, but take it a step further to the individual people. Attitudes may vary, but understanding and support can help people move from denial or resignation to taking action. Oglala.